My role here is a variety of things, including trying to figure out how do you take too few psychiatrists and spread them around better. So we know we don't have enough, and we've been exploring this psychiatric consultation model, consultation in primary care. It's kind of like an outpatient consult liaison. So there's been inpatient consult liaison psychiatry for a long time. This is outpatient consult liaison psychiatry to primary care, and then trying to figure out how to establish a presence, making these services available in many of the clinics in our Samaritan system. I think the way that I got involved in this goes back many years to the point where we were taking referrals from primary care providers and looking at what is it that they're sending us. And it became particularly acute when we started to have a growing waiting list, so we couldn't get people in. And I became more and more aware that there were things going on out there that we were not helping with because we weren't able to get those folks in to see us. And there were problems with, the national data say that primary care providers are providing more than half of all mental health services in the United States. So we know that half of all mental health care is taking place in primary care. If that's the case, perhaps we in psychiatry could help see that that's being done as well as possible. That was the motive. And if we can't have those patients come see us, then maybe we can have a presence there. So in the last couple of years, it's been trying to figure out different ways in which that might be done. The ways in which this psychiatric assistance in primary care has been offered run the gamut from educational seminars that happen weekly or monthly, as in the ECHO program, to an in-house psychiatrist who's available for referrals right there, and many different variations in between that involve increasing time on the part of the psychiatrist and increasing presence in the clinic. So we've tried a number of different variations to have that kind of virtual presence more palpable to primary care providers. In the long run, we've ended up with a mental health specialist in clinic, and we think that that might be ideal for our system. It's the route that we're going to try going now. We are using a variation of the model from the University of Washington, the collaborative care model, in which we have a mental health specialist who is a person with a bachelor's degree in our case, and then a whole month of in-house training on our part before we put them in primary care. They are our representative, our liaison with primary care, our data gatherer when patients are referred, oftentimes through a warm handoff kind of arrangement because they're right there in the clinic. They interview using a standard templated interview that we've designed so that they gather a standard set of information that's very similar to what we as in a psychiatric initial evaluation would gather. And then they chart that information so that I can look at it remotely and have that information to work from. Sometimes from just that information alone, I can relatively confidently arrive at a diagnostic impression and make a set of recommendations to the primary care provider. So that arrangement is extremely efficient. On other occasions, we are now entering into our plan to have a telepsychiatric connection to those clinics so that when I need to, I can interview the patient directly, again, for diagnostic clarification or for laying out treatment options. And all of that is then facilitated by the in-house representative, our mental health specialist. So why would a primary care provider think this is a good thing? First of all, what do they need? And then what do we think we can actually offer them? So a primary care provider might want this when they're faced with a patient whom they cannot get to specialty mental health for a variety of reasons. They won't go to the county mental health program. They've been to the county mental health program and they won't go back. They can't get to the county mental health program for transportation reasons or for some kind of funding or something, or it's a private pay client who just can't go to county mental health and cannot get in anywhere in any of they can't get to see a psychiatrist because there's so few psychiatrists taking new patients. So for any of many reasons, they might not be able to get to specialty mental health. And yet the primary care provider is kind of stuck trying to help this patient. Being able to get a consult at that point has been very valued by my primary care colleagues. So in many ways, in making a transition to this different style of practice, the psychiatric consultation model, It's one thinks that my client is the primary care provider. The patients are the kind of the raw material through which I'm doing this process, and the person that I'm really trying to take care of is the PCP. If I can help him or her do a better job with the patient, that's of course the goal, and in the process, if I can do some teaching so that their skill set is growing and their comfort level with dealing with the things that I'm being invited to help out with is growing, then I can kind of try to work myself out of a job, in the sense that as they get better and better and can do more and more, they need less and less in the way of consultation. So that's part of the model, is to use every case as an opportunity to teach a little bit, and that's really fun. CCOs around Oregon are trying to figure out how to do many different things, and how to offer psychiatric consultation might not be at the very top of their list. Figuring out how to do behavioral integration, how to get a psychologist or an LCSW into a primary care clinic, has been a priority that I think in many settings has come before, or that's the first place to go. Let's see if we can get that working. And then maybe after that we might turn around and think about psychiatric consultation. I would wish that they would be considered more at the same time, because these things have to work together. So that psychiatric consultation, I would hope, wouldn't come as an afterthought. It would become as part of the process of how do we do behavioral integration in primary care. Because you need all these levels of services. How common is it that a patient who is referred to a specialty mental health provider doesn't get there? And the national data suggests that the answer is less than half the time. So about 50% of the time, a little less, they actually get there. So if you lose half of the patients before you even get started, that isn't it's easy to beat that number. It's not a very good start. So moreover, patients really appreciate being able to get services within the medical home, within their primary care setting. They don't have to go to a different place. They don't have to really necessarily meet a brand new person if they can do this with their primary care provider. And they don't have to undergo the whole stigma of going to a specialty mental health program. So there are a whole bunch of reasons why being able to get mental health care in the primary care setting is a good thing. Patients really appreciate it on multiple levels. I've seen some cases that just turned out beautifully, and it's very rewarding to see that with a one-time consult we can get a very different outcome than was underway at the time.